Hello everyone. Today we are going to discuss about the rationale of using beta blockers in heart failure. Initially I found itself a little bit confusing when reading this box, as you know beta blocker itself has a negative inotropic effect on heart, which itself can further aggravate the heart failure. But you'll see here that we are actually using the beta blockers for the treatment of heart failure. Now the basic here is we are actually using the beta blockers mainly in chronic heart failure, but we may withdraw the use of beta blockers in case of acute heart failure. Now regarding acute heart failure, if you go to the NICE guideline, you will see that we are not using the beta blockers if the patient having acute heart failure has a heart rate of less than 50 beats per minute, or having second or third degree AV block, or if the patient is in shock. These are the conditions where we will discontinue the beta blockers, as they can further aggravate the heart failure. But if the patient has a chronic heart failure, we'll definitely use the beta blockers. Now the rationale for using the beta blocker, you can read this article from PubMed. Here you will see that they have explained that in heart failure there is an excessive sympathoadrenergic drive, which leads to the increased heart rate, and the cardiac myocytes end up using excessive metabolic fuel, which further aggravates the heart failure. But if we use beta blocker, it will reduce the sympathetic drive, which will in turn lead the cardiac myocytes having relatively a greater amount of oxygen for making a better contraction. And this will also prevent the cardiac remodeling, which are the hypertrophy and also the left ventricular dilatation. Due to these benefits, we are using beta blockers in chronic heart failure. And here you will see we are actually using these three drugs from the beta blockers: the carvedilol, bisoprolol, and metoprolol. Regarding carvedilol, we must exclude asthma first, as it is a non-selective beta blocker. It will be able to exacerbate the symptoms of asthma. Here it is suggested that it should be started at a low dose, and then the dose should be gradually increased, and tolerance must be noticed. These are some conditions where beta blocker treatment should not be prescribed. It should not be prescribed without diuretics. It should not be prescribed in patients having a higher degree AV block, or it should be used in caution with patients having second degree AV block. It should not be used in acute heart failure, as we have seen. There are some conditions, and also not in decompensated heart failure. And regarding carvedilol, we must be excluding asthma first. Okay, what does the NICE guideline say about chronic heart failure using beta blockers in chronic heart failure? It's almost similar. We should not withhold the treatment with a beta blocker solely because of the age or some other conditions, other comorbidities. We should start low, go slow, and then we should switch from a previous beta blocker which is not protective for heart failure. Say if the patient was having atenolol, we must switch from that beta blocker to those selective beta blockers which help to prevent the remodeling and increase contractility, which are the carvedilol, bisoprolol, and metoprolol. Thank you.